Hello everyone. We will discuss the wound management according to Australian guidelines. I'm Dr. Omar Shakori. I will be your tutor for this class. Our aims for this class are to discuss some notes about introduction of wound management, types of wound, steps for management, and this is the most important part of this lectures, the step. Antibiotic prophylaxis, very important in the emergency department. When to give antibiotic, when not to give antibiotic. Tetanus prophylaxis also. When to give tetanus, what is the type of tetanus prophylaxis that is available. Recommended suture size. Those are the important aims of this class. And the classification of suture material. So regarding introduction, daily in the emergency department, we are receiving a wounded patient. So I want you to understand this class very well. You will receive from the simple wound to the big wound to the burn. Even burn nowadays is considered as wound. You have to know how to deal with it. Proper wound management or proper wound preparation is very important. The steps that we will discuss are important because we want to restore the integrity and function of the skin. Also, we want to prevent infection and we want better cosmetic result for any wounded patient. So, types of wound. Who can tell me types of wound according to the degree of contamination? We have 4 types of wound. Clean wound, number 1. Thank you. Clean wound. Number 2, clean contaminated. Contaminated and dirty. Thank you. What we mean by clean? Now we want some information. The clean wound is that the wound involving, for example, the skin only and no hollow viscera is opened. I mean, there is no GIT wound involvement, there is no genitourinary wound involvement, and there is no respiratory tract involvement. Also, no infection is present. In this wound, the infection rate is 1%. In this wound, we don't need antibiotic. This is the most common wound presenting to the emergency department. Wound in the hand, for example. Wound in the leg. Wound in the abdomen. Wound in the chest, but not involving any viscera. This wound needs no antibiotic. The percentage of infection is just 1%. Okay? This is the most common presentation in the emergency department of wound. Except we have 2 situations we will give antibiotic in a clean wound. What are these exceptions? Immune deficiency, which is diabetic patient and immunocompromised patient. What else? And this is very common also. The second option is patient with the prosthesis. Patient with the prosthesis of the hip joint, hip replacement, knee replacement, patient with valve, internal valve disease and replacement of heart valve. Those patients also need antibiotic. And this is clean wound. Second is the clean contaminated. What do we mean by clean contaminated? What do you think? Clean contaminated is the wound that involving viscera and lightly contaminated. For example, gastric and biliary surgery. Like when we do post-operatively patient, we did intra-abdominal surgery for any reason, appendectomy, cholecystectomy, whatever was the operation. If we open viscera, if we open internal hollow organs, we have made clean contaminated wound. This is not the wound that presented to the emergency department. Remember, this is not the wound that presented to the emergency department. This is the wound that done by the doctors during operation, intra-abdominal operation. Okay? Here we have infection rate is 2 to 5%, and this patient need prophylactic antibiotic. There's a question. Patient with right inguinal hernia. We did surgery for right inguinal hernia, right herniorrhaphy and hernioplasty. Is this patient need antibiotic or not from scientific view? No. We are not speaking about emergency. Patient is elective patient. So this patient need no antibiotic as we do not open the viscera. If we open the viscera, for example, was the patient acute and we open the viscera, this is another type of wound, contaminated wound. So what's contaminated wound? It's operation on unprepared colon or emergency operation for intestinal perforation or bleeding. Here we have the contamination wound. For example, the patient with obstructed hernia and we did operation in the emergency department, or patient with abdominal injury, stab wound, we did operation for this patient. This is called contaminated wound. And of course, 3 and 2 need antibiotic. And contaminated wound infection rate is 5 to 30%. And this patient need antibiotic. What about dirty wound? Dirty wound is infection encountered during operation. Like, for example, if you open a pus or you open the abdomen and you found pus inside the abdomen. So this is, you see the pus equal infection, so this is dirty wound, and this is need treatment by IV therapeutic antibiotic. Okay, again, the most commonly presented to our emergency department, the clean wounds. Okay, the clean wounds need no antibiotic except in condition that patient is immunocompromised or patient with prosthesis. Clear? Any question, please? Okay. So how you manage the wound? There are 8 steps to deal with any wounds. Any wounds presented to the emergency department from 1 cm or half cm up to half meter, up to any size, any depth, there are fixed 8 steps for each wound. The first step is sterile technique. Before doing anything, you have to ensure of sterile technique. What do we mean by sterile technique? 3 points. 1 for doctor, 1 for patient, 1 for tools. For doctors, you have to wear your gloves. For patient, be sure that the patient took the povidone or sterilization and towel sterilization, the towel that you use it to cover the patient. And as for the tools, you need to be sure that sterile tool. Second step, after ensuring the sterilization, second step is to give anesthesia before touching any wound. Just imagine 5 years old girl, yesterday she presented to our emergency department with a forehead wound. How you will deal with this child? First thing, you will be sure of sterilization. Second, before taking the suture, be sure of giving her some anesthesia to keep her calm and steady. So either we will use local or regional. Regional is advanced, not available. And local, we are using, which agent we are using for local? Lidocaine. What is the dose? And this is your job. Now you have to know the dose. What is the dose of lidocaine? Who can tell me? Dose of lidocaine. Okay. It's 3 milligram per kilogram, and it's 5 milligram per kilogram if it's associated with adrenaline. It is short acting. You can give up to 200 milligram. There are some books said up to 300 milligrams. I will go with the 200 milligrams. There are 5%, there are 3 types of ampoule of xylocaine. There are ampoules mentioned the concentration is 0.5% and other 1% and other 2%. I want you to know what they mean by this. The most common that's available in our DOH is the 2%. When you go to the emergency department of any hospital inside Iraq, you will find that 2% is more common to be available in the emergency department. So what they mean by this 2%, they mean that there's 20 milligram for each ml of that ampoule. So let's suppose this. You have adult patient who is 70 kilogram and he is wounded and you want to give him some lidocaine. How much you will give? No. He is 70 and we want to give lidocaine. He is 70 kilogram. Okay, that's very good. The answer is 70 kilogram multiplied by 3, it will give us 210 milligram for that patient. And if we take each 20 milligram equal 1 mil, we will give 10 mil.5. The problem is not to give this 10 mil. Let's suppose that he has a large wound. So what you will do in this situation? No. You are not preparing for, this patient is not for GI. This is for local intervention in the emergency department. You give 210 by 10 cc. How you will deal with this? No. Not every time. Dilution. I want to make this 2% like the 0.5%. So I can add 30 cc of normal saline to this 10 cc of normal saline. So now I have 40 cc, 40 mil of lidocaine 0.5%. I can use it anywhere for the body. I can use it for a large wound. Okay? So what's available in our emergency is this one, the 2%. You will calculate it according to the weight of the patient, and then you will dilute it to give maximum area of anesthesia. Okay? Any question, please? Because this is very important. This is the most important part in dealing with wound from your point of view. You will deal with this daily, not one time, about 10 times per day in the practice. So please, if you have any problem in calculating this, I will repeat it again. Yes?
The patient needs a small wound. The same dose.
Those are the same. But you can give just, if it's small, you can just give 1 cc. No need to give the total dose. But the maximum dose should be, try not to go beyond 200, the total dose. Okay? What else? Okay. Who can, 5. No, it's more, not less. Adrenaline suppress the action of the lidocaine, so we give more milligram, 2 milligram more. Some books mentioned 4 to 6. Some books mentioned 5, so I took the 5 to make it easy for you. Yes. More, not less. More, not less. Because it intervened with the action of lidocaine, so we give more lidocaine. Who can suggest what is the next step? Now you ensure that this is our patient. We are wearing our gloves. The patient is covered with a sterile towel. I give the anesthesia here, the local lidocaine. What is next? Maybe. It's one of the steps, but not the next. Hemostasis, the most important step. Just I want you to understand that those steps, one follow other. Do not jump. Yes, one of them we will remove the foreign bodies. We will do debridement, but I want you to follow the steps. If you follow the steps in any wound, you will be sure that you will cover the wound management properly for this patient. So what are the hemostasis methods? Number one, pressure, direct pressure. Number two, ligation. We sometimes do ligation in the emergency department, but this is not your job. You have to call your uncle. Number three, cauterization inside the operation. If we do not control the bleeding, we do cauterization. Number four, finger tourniquet or pressure cuff proximal to the injury. As I told you, this is not done in the tertiary hospital, but we did it in the operation. We do this in the operation theater, proximal to the injury, and inflate above the systolic blood pressure to control bleeding, and we have to monitor the time for this. And this is done in the operation, not in the emergency. Orthopedic, general surgeon, vascular surgeon, emergency surgeon, all of us do this. I want you, if you receive a patient with a trauma and deformity, do this direct pressure. This is life-saving in the emergency department. Life-saving. Dr. Muhammad knows this. We receive a lot of patients with femoral artery injury. What we did for those patients, just pressure on the site of injury. Even if he was fractured, I want to stop bleeding by direct pressure. Okay? What is next? Step 4. Foreign body removal and hair removal. Debridement is the 6th. Foreign body removal and hair follicle removal. Remove the hair, which can act as a foreign body by clipping, not by shaving. Unfortunately, in the emergency department, even in the operating theater, in our locality, they remove it by shaving, not by clipping. Unfortunately, I tried to change this, but they want more fast to do just shaving. So shaving may damage the hair follicle and allowing bacterial invasion and can increase the infection rate by 10-fold. This is the problem with the shaving. We have to do clipping. We don't have the facility to do clipping in the emergency department or in the operating theater. Number 5 is irrigation. Number 5 is irrigation. So I will back again. The first step, I did sterilization, sterile technique. I ensured that sterile technique. After that, anesthesia giving to the patient. After that, hemostasis secured. After hemostasis secured, we remove the hair follicle, we remove the foreign bodies. And after that, we will do irrigation. Irrigation by what? Use low pressure irrigation if you have uncontaminated or clean wounds. Just like if you have the normal saline, just let the fluid go easily to the wound. While if you have a contaminated wound, we need someone to pressure, to make high pressure. Unfortunately, we don't have the device who ensure that we are giving 0.5 psi or 7 psi. So if you have contaminated wound, you will use high pressure irrigation. And if you have non-contaminated, just let the fluid go loosely to the wound. We use normal saline inside the hospital, but remember, if you are in the situation that not in the hospital and you have a wound, that tape water is safe and effective. This is very important. If you have, during situation, I wish no one will experience this again, in situation of war and you are working in the home, you receive a patient who is injured and you don't have any facility of normal saline, remember, tape water is safe and effective, and this is documented. not from me. In Australian guidelines, they use sometimes tap water. Number 6 is debridement. What we mean by debridement? Removal of dead tissue, exactly. Removal from foreign matters, bacteria, and devitalized tissue. That's what we will do. After we irrigate the wound, now the wound, we can see the dead tissue. Okay? Number 7, antibiotic. Prior to manipulation. Before taking this decision to put your needle, you have to give the antibiotic. So, prophylactic antibiotic, I will say it again. Indication, if you have a clean contaminated, which is number 2 in types of wound, or if you have contaminated wound, which is number 3 in the types of wound. Or if you have clean wounds in 2 conditions, also we mentioned immunocompromised patient who is diabetes, renal failure, chemotherapy patient, those are immunocompromised. You have to give antibiotic even in a clean wound. Also, infection suspected in prosthesis patient, valve replacement, total hip replacement. Those are the main indication for prophylactic antibiotic. What is the dose? We will give 1 to 3 doses and not more than 72 hours. Best time is at the induction of anesthesia, at time of surgery, IV, IM before 1 hour or rectally before 1.5 hour, and also can be used topically in eye operation. Any question until here?
الاورال نعطي بروفيلاكسس بس الابسس ديرتي ووند اي في.
Clean contaminated wound. Number 2 in the types of wound, which is the wound that affect the hollow viscera, like the surgical wound for operation inside the abdomen.
هو دكتور قصدي يعني الانتيبيوتيك البروفيلاكسس اورال يكون بس بال
We can give it orally for 3 days. The best is now is IV at time of induction of surgery. I will do operation for intestinal obstruction. At time of induction of anesthesia, I will give the first dose of antibiotic. Okay? And I will continue for 3 days. Any question? Bale, doctor. Best antibiotic, you have to tell me. Not broad spectrum. Start with penicillin group. Start with penicillin. Not the idea is to give a gram-negative. Just, I want you to understand this. The problem, the most common microorganism in the life is a staph. The most common microorganism around you and involving your skin is the staph. When you open the wound, the staph will enter inside the wound. So you have to cover this most common infection. So we give penicillin. The problem is that if the patient has allergy to penicillin, what you will give? Clindamycin. Clindamycin. Okay? Any question? Okay. Tetanus prophylaxis. Step 1, we have 3 steps. Step 1, you have to know the type of wound, whether this type is clean or this is dirty wound. I would say clean and dirty wound. Step 2, to know immunization history of our patient. Fortunately, that all our patients are non-immunized, so all have the same categories. Rarely you will face an immunized patient. One time I received a patient with wound and she is not from Iraq, working with the NGO. She's Australian and she was vaccinated. Okay, this is only occurred one time during my life. So all our patients in Iraq considered as non-vaccinated patient. Step 3, you have to know what to give. We have 2 types. We have tetanus immunoglobulin, we have tetanus toxoid. Sometimes the tetanus immunoglobulin available, sometimes the tetanus toxoid available, sometimes both are not available, sometimes both are available. Okay, we will discuss the scientific way what to give. So, wound classification. As the first step, we want to know the type of wound. Is it a clean wound or is it dirty wound? To make it easy, this diagram will show you. If you have wound less than 6 hours, this is considered as tetanus prone. If you have more than 1 cm, this is tetanus prone. If you have missile, crush, burn, frostbite, those are tetanus prone. If you have devitalized tissue, this is tetanus prone wound. If you have contamination by dirt, feces, saliva, and soil, this is tetanus prone wound. Yes. No. No. And one of the mistakes. Now, what to give? The first question you will ask yourself about tetanus. Is the patient clean wound? And this is the clean wound. Is the patient has all others wound, or let's say the dirty wound, to make it easy. So the first step, I will check clean or dirty. The second step, I have to know this is unknown immunization or immunized patient. The third step, I have to take a decision to give tetanus toxoid or tetanus immunoglobulin. So let's start with the most common in our locality. The most common in our locality is to receive a patient with a wound, and this wound is contaminated with soil or dirty, and our patient is non-immunized. Again, non-immunized patient with dirty wound. I will take a look. This is the dirty wound, and this is non-immunized patient. What I will give? I have to give both tetanus toxoid and tetanus immunoglobulin. Clear? This is the most common situation. Unfortunately, not every time those both are available. So give what is available for that patient. If both available, give them both, the tetanus immunoglobulin and the tetanus toxoid. Which is the vaccination, the immunoglobulin or the tetanus toxoid? Toxoid, thank you. What are the doses for immunization of toxoid? So still, this is our patient. Let's suppose that I want to give this patient vaccination. Our patient who has dirty wound presented, and I give him tetanus toxoid and immunoglobulin. I want to put him on a schedule. What are the doses of tetanus toxoid? Remember, day 0, 6 weeks, 6 weeks, 3 months. Day 0, 6 weeks, 6 weeks, 3 months, and booster 5 years. Okay? Now, what if the same patient from our locality, we receive this patient with a clean wound? Just a simple wound by knife, let's say by knife. A female, while she is working on the kitchen, and she injured her left hand by a knife. This is a clean wound. What you will give? And she is not immunized. What you will give? The immunoglobulin should not be given unless dirty wound. So no immunoglobulin, we will give no immunoglobulin. We will give just the tetanus toxoid. We will give just the tetanus toxoid for that lady. Okay, clear until now? Okay. What about the immunized patient? Immunized patient, if the immunized patient has a clean wound, nothing needed. If this patient has a clean wound and he is immunized, this patient need nothing. Just we will give tetanus toxoid if the last dose since 10 years. If the last dose since 10 years, we will give tetanus toxoid. So ideally, we will give nothing for a clean and immunized patient. Regarding tetanus prophylaxis, for dirty wound and immunized patient, we will also give nothing. For an immunized patient, we will also give nothing. We will just give tetanus toxoid if the last dose received within the last more than 5 years ago. Okay? I will repeat those again. If we have dirty wounds, an immunized patient, and this is the most common in our locality, we will give both. If we have dirty wounds in immunized patient, we will give nothing, but we will give tetanus toxoid if the patient received his vaccination more than 5 years ago. Now, what about a clean wound? If we have a clean wound in non-immunized patient, we will give tetanus toxoid only. No need for immunoglobulin. This is a clean wound. If we have a clean wound in immunized patient, we will give nothing unless the last vaccination was 10 years ago. Clear? Okay. So, to make it easy, if lacerated wound or dirty wound, if he is vaccinated, no need for immunoglobulin, and we will give tetanus toxoid if the last dose more than 5 years. If not vaccinated or unknown vaccination or less than 3, we will give both. If a clean wound vaccinated, we will give nothing unless it's more than 10 years. If not vaccinated, we will just give tetanus toxoid for that patient. What if kids? All of us are non-immunized against tetanus. What about the kids who are receiving DTP vaccine nowadays? What about them? Less than 10 years. So we will speak about the kids less than 10 years. Above than 10 years, we will deal with them as adults. Less than 10 years, consider all wounds other than clean minor wounds should be considered as tetanus prone, and they will receive tetanus immunoglobulin only, no need for tetanus toxoid. So let's say 7-year-old boy presented with a wound in the hand, and this wound was dirty. What you will give? Tetanus toxoid or tetanus immunoglobulin? Immunoglobulin. No need for both in the kids below 10 years. That's the idea. What you will do if you are in the emergency department and the available is just tetanus toxoid and you receive this patient? The 7 years. No need. No need. It will give no benefit for that patient. Okay? Nothing. Nothing. Clean wound need no immunoglobulin. Okay? Any question? A pregnant, we will not give her. We will keep her on schedule. The diphtheria, tetanus, and porphyria, I don't remember the P. DTP. Pertussis, thank you. DTP, she can receive it. Now, classification of sutures material. We have absorbable, non-absorbable. I prefer that this will be discussed in the emergency department with the available sutures material. Uses of, we mostly use the absorbable sutures in the emergency and in the operation. The skin closure, especially in the kids, the subcutaneous closing, we are using the absorbable suture. For hemostasis and tying of the arteries, bleeders, we use the absorbable sutures. For halovisceral, like anastomosis of end-to-end anastomosis of intestine, we are using absorbable suture. For small bowel also, we are using the absorbable sutures. The suture size and material, the best option for laceration localization. If you have a scalp injury, you can, the best is to use 4-0 nylon or Prolene. If you have face wound, the best is to use 6-0. and also Prolene or nylon. If you have a trunk, the best is to use 4-0 nylon. If you have extremities, also 4-0 nylon. If you have digits, the best is to use also Prolene or nylon 5-0. Any question? Any question? Thank you very much. This lecture also will be available on my channel. Thank you. You have your free time now. Thank you for being with me in this class.